Our next presenter is Dr. Carl Christian Jackson. He's an assistant professor of pediatric surgery at Tufts Children's Hospital. His presentation is entitled Pediatric Surgeon-Hospitalist Comanagement Teams Minimize CT Use at Community Hospitals when Evaluating Acute Appendicitis.
Thank you. Good afternoon. I appreciate the opportunity to present our work. I have no conflicts to declare. As you know, distributed care models are becoming increasingly common as a way to extend the expertise of academic medical center physicians, in this case pediatric surgeons, to the community hospitals, thereby allowing patients to receive care closer to home. A major challenge with this approach, though, is how best to triage and manage patients effectively. In particular, how can you triage patients so that the surgeon is focusing their travel on the sickest patients or the ones with confirmed surgical disease? Imaging plays a critical role in this evaluation, and while ultrasound is preferred, it carries the limitation of being operator-dependent and can be non-diagnostic. In these situations, CT is often used reflexively because it's objective, frequently, although not always definitive, but it does carry a significant cost of radiation exposure. Our approach to managing this challenge was to develop hospitalist surgeon co-management teams at 2 of our affiliated community hospitals. And in developing this model, we collaboratively created clinical pathways so that we had common pathway for managing surgical diseases such as acute appendicitis, and also had expectations of clear attending-to-attending communication for all patients. In this way, with these teams, every patient could be immediately evaluated by an on-site team member, and, for patients where the diagnosis was equivocal, they could be admitted for serial examinations rather than reflexively receiving a CT. Our study design to evaluate our success with this model was to perform a retrospective chart review of patients under 18 years of age with acute appendicitis. We chose CT utilization as our marker for quality and patient safety, and our comparators were a resident care model, which is the pediatric surgery service at our academic center, the 2 hospitalist care models, and then a community surgeon-only model, which is at another affiliated community hospital where adult surgeons are providing pediatric surgical care but without routine involvement of the on-site pediatric hospitalists. This table shows our baseline characteristics and the number of patients for each care model across the top. We did see a significant difference in patient age across the sites, with the lowest age being at the academic medical center, which is consistent with it being a tertiary care referral site. However, the true clinical significance of this age difference is probably small. CRP as a preoperative marker of disease severity was also higher in our resident care model, again, likely a marker of its being a tertiary care site. In looking at disease severity based on pathology results, we found that the community surgeon-only model had the highest rates of uncomplicated appendicitis, which was expected given their typical routine of transferring the sicker patients to dedicated pediatric sites. As we look at imaging, we see an interesting correlation where sites with the highest ultrasound use also had lower CT use, and the CSOM had the highest utilization of CT across all the sites, in particular as the only imaging modality for children or as a follow-up to a negative or equivocal ultrasound. Interestingly, this higher CT use did not correlate to a lower negative appendectomy rate, as there was no significant difference across the sites regarding negative appendectomies. When we look at CT use longitudinally over the study period, the prior table was looking at the aggregate numbers. We see that the resident care model site had consistently low use of CT. The CSOM had consistently high and the highest use of CT over the time period. And our 2 hospitalist care models started high, consistent with their being community sites, but showed a rapid and sustained decrease in CT utilization. When looking at ultrasound, again, we found the best utilization at the resident care model site. And while ultrasound use was very low initially in the community, in the CSOM, it did show a marked increase, but it did fluctuate significantly over, or markedly over the study time. Again, the hospitalist care model sites started with low utilization, rapidly increased, and sustained this increase to the point where they were nearing the academic site as well as regards their utilization. So we found through this evaluation that patient safety in children with acute appendicitis improved significantly over the study period in our hospitalist care model sites through decreased CT utilization and therefore decreased radiation exposure. And of importance, this lower CT use did not equate to a higher negative appendectomy rate. So we concluded that involvement of pediatric hospitalists as part of a care management team can decrease utilization and improve patient safety. We also found that this co-management model was an excellent way to extend the clinical reach of pediatric surgeons, and this is something that can be applicable to both private practice and academic models. And further, as the hospitalist became an integral part of the surgical team, the clinical care of children was enhanced throughout the study time. I'd like to acknowledge the Department of Pediatrics and the Tufts CTSI for statistical support, and our medical students who are involved with data acquisition. I'm happy to take any questions. Thank you.
All right, this presentation is open for questions.
Hi, Tim Lautz from Northwestern and Lurie Children's. Great presentation, and I applaud you on this work and really important effort to reduce the CT use. Have you guys thought about implementing an MRI protocol and perhaps in a kind of hub and spoke model, starting that model at the Children's Hospital and then from there expanding it to the other institutions? We've in Chicago been able to do that successfully, doing over 1,000 MRIs at the main hospital and then eventually being able to spread that to the community hospitals as well.
Thank you for the question. I think that's an excellent point. We have not considered that yet, but I think that would be a great next step, particularly with the hospitalists being on site as a means to help push this. It expands our reach both for the care as well as for implementing these new approaches. Thank you.
Thanks. Yeah, and it can be done as a 5-minute study.
Yes,
Question.
sir.
Hey, Trey Eubanks, Memphis, Tennessee. Great presentation. I was just wondering, what is your approach to improving the outside facilities following the guideline, and did you have any care guidelines that were developed either on EMR or any type of educational, electronic educational updates to decrease the ultrasound use?
Thank you. At this point, we are partnering with our hospitals at that community surgeon site, providing them with the data, because this sort of came to fruition more recently. And we would like to get their help with trying to improve CT utilization at that site. So that's through the hospitalist team there is our goal. As far as the EMR, we have not thought of that approach yet, but I think that would be an excellent way to make it more straightforward and provide less thought as far as moving towards ultrasound rather than CT.
Well, I think going forward, this is going to be a care model we see a lot of, where we're influencing partner sites and figuring out the best way to do that so we can decrease CT utilization is a great goal to have. So thanks for the work.
Thank you.
All right, we have a question from a virtual participant.
Yes, Dr. Pokal says, did you use any survey data like Alvarado scores or anything like that?
In this case, the Alvarado score was part of the clinical pathway that we developed, but in this, we did, because it was not used across all sites, we did not include that in this data analysis.
All right, thank you very much.
Thank you.